Good afternoon, folks, and welcome to our panel discussions on engineering in surgery and intervention. My name is Mike Miga, and I'm a professor of biomedical engineering here at Vanderbilt University, and I am also the director of the Master of Engineering in Surgery and Intervention program here at Vanderbilt as well. For those that may not know about our program, this is a professional Master of Engineering program, and it is designed to provide advanced technical skill sets at the cutting edge of surgery technologies. It's also meant to provide aspects of professional skill development. We also have a capstone design that is an experience where you build your own prototype as part of the program. And lastly, our hallmark is our clinical immersion experiences, so folks get a really good understanding of their prototypes and how they would actually work in the operating rooms or interventional suites and really get a sense of that working. So if you're interested in the program, be sure to look it up. You can find us, again, it's the Master of Engineering in Surgery and Intervention program. You can find it on the web. It's at http://vu.edu/ESI, and we'll send that website up later as well. So with that background done, in our previous panel discussions, we've discussed the role of engineering in surgery intervention with respect to a lot of different areas. We've looked at open software development. We've actually looked at career trajectories as well. We've done some work with robotics. We've done some work in digital twins and next generational devices. Last panel, actually, if you want to catch that, we actually looked at constrained resource engineering for surgery and intervention. So we've done a lot of interesting work in the past. In today's panel, we're going to do even a more intriguing topic. We're going to look at artificial intelligence. You've probably all have heard of large language models and things in population analytics. But today, we're going to be talking about its impact within the domains of surgery and intervention. And so with that, to chat about these things, I've invited two folks to our two panelists today. And so let me begin by introducing them one at a time here. So first we have Dr. Ipek Uz, who is an associate professor of computer science here at Vanderbilt. She's also appointed in electrical and computer engineering, with a nice wave, and biomedical engineering as well. Dr. Ipek Uz's research is at the interface of medical image analysis and artificial intelligence methods. Lots of different work in machine learning. What I like about Dr. Uz's work is that several of her projects are concerned with what I call kind of interventional medical image analysis, which is kind of neat. And so we'll hear about that shortly, and that's how the surgery comes in. Our second panelist today is Dr. Zhiying Wu. She's an assistant professor of computer science at Vanderbilt, and a nice wave there as well. She's also appointed in biomedical engineering and electrical and computer engineering, as well as in mechanical engineering. Dr. Wu's expertise is in using machine learning techniques to improve tools in the operating room, such as transforming surgical robots from a teleoperated tool to an intelligent assistant. So I'm kind of really interested to hear about that. What I love about Zhiying's work is that it sits at this really interesting interface point between surgeon and robotic technology and kind of how they kind of work together. So how do you achieve that kind of interaction intelligently? It's kind of a really interesting area. So in full disclosure as well, myself and Dr. Wu here are co-PIs on a grant from the Wellcome Trust. So there you go. So welcome to both of you. I appreciate you taking the time. I know your schedules are quite ridiculous, and so I really appreciate you taking 30 minutes out of your time to just kind of shoot the breeze with us.
Thank you for having us.
Oh, no, it's great. So let's jump right in if that's okay. So I'll start with you, Ipek. So before we get into kind of bigger topics, part of the panels is really just to introduce topics to some degrees, if maybe folks don't know about it, because our Master of Engineering program appeals to not only biomedical engineering, but obviously computer science and mechanical and electrical. And so I guess as a broad definition of kind of artificial intelligence, kind of based on your background, kind of how do you view it as far as what it means to you? And then, maybe, what's the difference between AI and machine learning, which I always have to look it up all the time. And then kind of what drew you to kind of this type of work?
Yeah, those are great questions. Okay, let me start with the difference between AI and ML, right? Machine learning. So I think the way it is used right now, with like all of the hype around machine learning and deep learning, I think the mainstream media started just calling everything AI because that just sounds, more fun than saying machine learning or like supervised learning or something, right? But I think so right now, I think we are using it just interchangeably. But in reality, like if you ask any computer science faculty, like you are right now, we'll tell you machine learning and deep learning are just sort of subsets of what comes into AI. So AI is a more broader field. And with machine learning, I would say that Let's see, how do I define it? I guess I would say that anything that is data driven as opposed to like rule based and programmed explicitly. So like if you are trying to, I do a lot of medical image analysis, right? So I think about this in terms of images a lot. But if I'm saying like find the object that looks this certain way and then like, has this and this properties and so forth. Like if I am just programming a set of rules, that's not machine learning. Versus if I say, here's a bunch of examples, figure out what it is that I'm trying to get. And that's more machine learning, deep learning kind of work.
So what drew you to it too? Just
Well, I mean, I've always wanted to be a computer scientist. Even as a little kid, I had like a plastic keyboard I was playing with. So it was very clear this is what I was gonna do, right? But yeah, I'm also very visual. I like playing with images. So this medical image analysis was a very obvious choice for me, and I think it's I would say it's going well. Yeah.
So Zhiying, I mean, so maybe a little different twist on that. I guess in terms of AI, how can you kind of convey how powerful it is, and what is your thoughts on that, kind of how powerful a tool is, and what drew you to the same kind of work?
Oh gosh. So unlike you, Peck, I didn't always know I wanted to be a computer scientist. In fact, if you look at my degrees, all four are in different things because I didn't know what I wanted to do. So I think that's what's fun about AI for me, that it goes a little bit beyond machine learning, that you're trying to learn patterns from observations from data, that it brings in like the computer or the physical embodiment actually does something. And that's the part I'm interested in, the does something part. So if we have a tool, how can we make it better, that it's not just a passive tool that the surgeon is holding, but maybe it gives feedback on like, hey, you're not doing this correctly. Here's what an expert would instead do.
Yeah, let's explore that a little bit further. So, like, your area is kind of this robotics and intelligent surgery. I mean, can you give us a little bit of an idea? Can you speak to how AI, works in this area, and kind of a little bit of a sense of that kind of problem domain?
Yeah, so as you mentioned, we're part of the Welcome Leave grant, and there we're using AI to analyze. Well, I guess we're using machine learning to analyze the feedback from the surgeons doing these ex vivo studies on organs, and we learn like, hey, you're at this level of proficiency. Here's the patterns you're doing that makes you this level of proficiency. And a bit beyond that, the more AI part where we just program, if the machine observes from data that this person's at this level of proficiency, here's what the machine should do to help them move to the next level of proficiency. And we bring in other tools like augmented reality with eye gaze tracking of having novices being guided by more than just the expert telling them what to do, but also seeing what is the expert looking at and what's expert actually, would the expert be moving the tool. So AI really enhances the training process for surgeons, that they get this multimodal feedback on how to become better surgeons.
Yeah, it's super interesting because you're using kind of these techniques to really identify and label all the different parts of the procedure, and trying to identify all the different, when a surgeon goes bad and when a surgeon does well. You're kind of really using these kind of more automated methods to really kind of hone in and see things. It's really interesting work. I love it. It's really super. I like every time we have lab meeting. I kind of love it. So Ipek, you're kind of a different direction. I mean, in some sense, you're not. You're speaking to a different area in terms of what I call interventional medical image analysis. Can you give us some sense of kind of AI, how it impacts that area, a little bit, kind of what that domain is like, and some of the challenges and things that you see in that area?
Yeah. So I think it's kind of interesting when it is interventional versus just medical image analysis, because like for the longest time, for 15, 20 years now, I have been working on just static images, right? So somebody acquires an MRI of a patient, then uploads it maybe a few hours, maybe a few days later to some server, someplace for me to access to, and then like I analyze that in my own time, right? And there's no time pressure or anything like that on it. But with international stuff, it is happening all in real time, right? If I'm going to be doing anything useful to the surgery, I better do it while the surgery is happening. So I think the real time aspect of it is very interesting. And the good thing about these AI methods, deep learning methods, is that with the acceleration in the hardware, with the GPU acceleration, it's possible to do some of this in real time, right? So I think it's a big sort of jump forward in what we can do in that space. So one of the projects, for example, we're working on is with Nick Abusi here at Vanderbilt Medical Center. where we are looking at endoscopic kidney surgery. So this is for removing stones or kidney tumors, where it is done endoscopically, and it becomes very challenging for the surgeon to figure out where they are in the kidney because it's a branch structure, and like you are looking at it in pre-op images, where it's a very different view than like when you are in the during the surgery. So it's very difficult to figure out where you are. Have you checked all of the different branches to make sure that you haven't left any stones behind? So we're able to help with like the navigational system, sort of like a GPS for the endoscopic surgery, right? So this is like, you know, those like you are now here kind of maps. We're trying to do that kind of thing for the kidneys. And then we're also able to help when there is as the surgery goes on, there's like a lot of debris and sometimes bleeding, and so the surgical field becomes very, very messy, right? And the visibility is impaired. So we have worked towards helping with sort of improving the visibility in those conditions. So those are like, you know, I think good examples of the kind of interventional AI, what we can do with that. Yeah.
Yeah, that's really cool. You touched on a lot of interesting points. Like, you know, I've been around long enough to be static image based kind of person. I understand that really well. And I think, you know, one of the things that you mentioned that was really, it's really kind of leapt us forward is this idea of fast computing and GPU enabled. So we really have gotten to a point where the hardware is incredibly fast, which, you know, when you listen to all the commercials on AI, they're always talking about hardware solutions, right? So we've gotten to that point where we can take what I would consider, you know, 15 years ago, the image analysis methods were things you would wait for. I mean, more or less, you'd then execute your process and you'd wait a little while and it'd come out and you get your result. That's great.
It wasn't always a little while, right? It used to be like if you're on free server, it takes 24 hours. This was like well accepted in the community. Yeah.
Yeah, I mean, and your processes, you're doing them at speeds where you're, you know, the surgeon's using the devices and you're like processing all these things and helping them localize.
That's
It's
right.
pretty
That's
amazing stuff. I mean,
yeah, I think yeah, a lot of it is just technology has developed a lot, and both the hardware and the software technology has come a long way. Yeah.
yeah, I mean, and we're getting to the point where, you know, we have enough data kind of going on, you know, acquiring, because you know, technology's been in all these different procedures. I mean, part of your project, I think, remember, is you're actually looking at videos associated with stone disease and processing them as part of your training sets to kind of do this recognition work as well.
That's exactly right, and that goes to sort of what I was talking about earlier, where it has to be a data-driven approach, right? Because if I have to say like this is what a stone looks like, then I have to be like it's hard for that to generalize because there's just so many different kinds of scopes that the surgeon might be using. The anatomy is obviously very different from person to person, and then like the kind of things that you like, the kind of pathologies that you might encounter are very different. So like just having a diverse data set to train on just sort of helps me with get away with trying to specify everything I can possibly think of, which is like always going to fall short, right? So I think that's really cool way to handle that problem.
Yeah. Okay. So this is good. This is a good lead off in here, which is, so you've got this cool technology, you're building all this kind of nice stuff, and you know, you're have this automated algorithm. As far as like the audience might have some folks that are looking at, you know, getting into this area, and so, you know, that's the positive side. You've been able to do all this stuff. What's been some of the design challenges? I guess, is there something about, you know, in terms of your development, what you've seen, what are the challenging things in design that you have kind of problems with that, you know, it's kind of the thing that now you have to solve all these things, right?
Yeah, I think it really depends on the specific problem you're working with, right? So to go with that same example of the kidney surgery, the endoscopic surgery, so for example, we have a project where we're trying to see if we can predict from watching the video if this patient is going to have residual stone that is going to require a future resurgery, right, a repeat surgery. And so the challenge there is that we don't know, like the surgeon doesn't know just watching the video, right? And they can take a guess, but it's not always clear. And with these data driven models, that we have to have something, the ground truth to train on, right? So we need to have some sort of a way of establishing this. And this is also a similar problem if you're trying to, like, for example, estimate the grade of a tumor or something like this, where like you can't take a guess, the surgeon can't take a guess, but you don't always know without having some other external ground to it. So we have to design experiments such that we have access to this. So for example, if it's, you know, a tumor grading, maybe we need to also include the biopsy results from it, which is not just available from just looking at the video, right? Or maybe like we need to see if the patient, you know, wait and see if the patient does need a repeat surgery or not. So you have to sort of like work around like these experiments where like you need to have the data that you need that you need to be able to train your model, right? And so trying to figure out how that works is a little tricky, which is like, if you think about like other computer vision problems, if you're trying to classify cats from dogs, like we can't do that. Like we don't need to wait around or design a specific experiment for that. So it's a little bit more challenging in that sense. Yeah.
Yeah, that's super interesting. I mean, so you're looking. I mean, obviously, the data is always a bottleneck in the sense of trying to get enough. But I love the idea of trying to use new avenues of using that data to do like prognostication and things of that nature. Those are kind of really interesting problems that are yet untapped, but clearly they would have huge impact if you can help the surgeon to essentially stratify patients right there on the fly. That'd be great.
That's right. That's right. Yeah, exactly. Because like otherwise, if they have to get that biopsy before they proceed with like what decision they're gonna make for the care of this patient, then that's a huge lag time added to the surgery, and then like the longer the patient has to be under anesthesia, like there's just lots of complications, right? Whereas if we can do this just based on the video, which is a big if still, but if we can, that's a huge help for the surgeons and for the patient care. Yeah.
Yeah. So Zhiying, kind of same idea, but you're again different domain. The design constraints are different. The environment's actually a little bit different for you because you're more of an interactive domain with robotics and things like that. What kinds of design challenges you've solved a bunch of things already, but what are you looking at, and what are those things that students might want to know about that are really interesting things that you have to now overcome or figure out solutions to?
Oh gosh, so many.
Yeah, sorry.
No, one thing that, so a couple of things. First, one thing my lab's been really struggling with recently is how do we know when we've done it? What's our, as Yipek mentioned, we don't have ground truth. So say we're trying to reconstruct a kidney and we reconstruct a kidney. Do we know that this is the actual one of the patients? We have some idea of what the kidney should look like from CT, but in the surgery, the kidneys look different. That's not the same shape as they would have on their CT scan. So that's challenging. But in a different projects, we're cutting out tumors out of people and then 3D scanning them and trying to give the holograph of the 3D scan tumor back to the surgeon. But once we 3D scan it, it's also not what that tumor looks like when they're in the patient body. So now, like, every single occasion, we have some mismatch between when we're actually able to image something versus what we think that shape should be. And so for my students, that brings me to the second challenge. It feels like I want so many skills from them. They need to understand how biomechanical model works because of tissue deformations. They need to know robotics from mechanical engineering. They need to know computer science to do all of this machine learning stuff. So it's a really unique skill set that I'm asking for, I think, to do the research in my lab.
So let's stick with this a little bit further. So you've highlighted some projects. These sound super challenging to me anyway. Knowing that I know what you do, I'm like, oh my gosh, it's so. But I guess as you think of a couple of your projects, if you were to kind of fully realize it, like, so you kind of have it in your mind what you're thinking this is going to. Yeah. If you were to fully realize it, how do you think that affect patient care? Like, what's your kind of vision of that full impact? I guess, do you have any kind of sense of where you're going and what the potential impact would be?
I mean, this depends a little bit on each.
Well, pick a project.
Pick a project. So I'll pick the augmented reality for head and neck surgery that you're also involved
That's
in.
A good one, yeah.
So as mentioned, the clinical challenge here is you have a patient, they present with a tumor. For head and neck surgery, you're really trying to remove all of this tumor at once in a lump sum. And ideally, you would get some margin around this. The surgeon goes and cuts a tumor out. They don't know whether they achieve their margin, especially the deep margin that's like into the patient. So they send it to pathology. Pathology cuts up this tumor and they're like, oh, there's some like mismargin over here, go and cut more. But the tumor is cut up. They don't know what here is, where this margin came from. And so the impact that AI and augmented reality guidance systems could have would be to then place the tumor as it was before pathology cuts it up back into the surgeon's hands to replace onto the patient so they know exactly where here is and where the how the pathology report matches to the patient. And then we can reduce recurrence rates in the head and neck cancer cases. And but more broadly, I think the impact of AI is to bring more sources of information into the operating room for the surgeon to access to improve healthcare.
No, that's awesome because I think it's something where 70 to 80% of all cancers are treated with surgery, and so you're really trying, I think it's really I appreciate that in the sense of you're really trying to figure out ways of improving the actual procedure and be able to kind of capture more of that margin, kind of pull more of the disease cells out in that sense. And I think it's what's cool about that too is the whole idea of debulking and kind of removing as much cancer, obviously there's microscopic disease and things like that, but the more you take out, the more likely you are to make the adjuvant therapy, the different therapies more effective, like radiation and chemo that might follow or be concurrent with. And so it really is kind of an all out assault. And part of that is really kind of what you're doing, which is, can you make that surgery more precise? Can we do the resections and sparing the tissue we don't need to, as good as we can in order to kind of, that's really interesting.
And it's interesting how, like, once you develop the technology for one surgery, you can find a lot of uses for other surgeries. Like, I work with a head and neck surgeon, but then sarcoma people came to me and it's like, we want to see radiation maps projected onto the patient so we know which tissue is still healthy and what tissue isn't. And I've had pediatric liver surgeon come also to see, like, here, where are the vessels coming into the liver that he should avoid cutting while he's performing his surgeries.
No, that's great. I think it's awesome. I think it's super interesting, and translation is definitely a theme of this panel. So I think that's the idea of taking our technologies and moving it in different places. It's perfect. Ipek, I don't know if you have a quick example similar to this in terms of the I guess any one of your technologies. What do you think the impact will be if you were to fully realize it? Maybe you could just
yeah, so let me give an example from a different project. So this one is on placental imaging, ultrasound imaging of the placenta, and in collaboration with the University of Pennsylvania with Dr. Nadav Schwartz, where we're trying to see if we can use these ultrasound images of pregnant patients to see if we can predict fetal outcomes, things like, is the baby going to be, too small for gestational age, things like that. And we're trying to do this longitudinally across different trimesters to see like the fetal growth trajectory as well. And what we're hoping to do is to put this actually in the clinic so that like when the technician, the sonographer gets the image, we can get the data right away, that both whether it's a good enough image, because with the fetus moving around in there and the mom breathing and stuff like that, there's like the image quality is not always great. So if they take the image, upload it to me, I don't look at it for a week, then like that's way too late for me to say no, go back and take another image, right? So to be able to do this while the patient is still there in the room and they can get a repeat image if they need to, maybe like the placenta is not fully in the field of view, so they need to move the probe a little bit or something. So you'll be able to do those things and then also use that for interventional. So if they are, we're not there yet, but if we can say this patient is at risk for a poor outcome, then like the prenatal care can be adjusted based on that, hopefully. So that would be sort of like a long-term impact of this project.
That's awesome. So we've covered sarcomas, kidney. Now we're into pediatrics. This is great. We're covering all our bases as well as head and neck surgery as well. So we're in good shape here. So this question's to both of you. I'll kind of go through. I'll start with Ipek first. And so one of the things about the master's program is this idea of clinical immersion and the value of really seeing the workflow and the domain kind of up close and personal, and it's difficult kind of to see that. But I guess I was curious, how important for the students that might come and work in your lab, like how important is it for them to understand that environment? Like, does it shape the work really well? How I don't want to feed into it, but how does it actually impact? How important is the experience?
Yeah, I think it's hugely important, right? So a lot of my students are computer science students, not biomedical engineering students, so they don't have a lot of the domain knowledge to begin with. So they're they're good at machine learning, deep learning, or they get good at it. But if they don't have the interaction with the clinicians, then it becomes sort of like almost a theoretical exercise. Obviously, it is still based on the application, but it's not like really deeply rooted in that, right? So it becomes like I always see in papers or presentations like brains that are sitting sideways, which like I have seen enough brain images at this point, even though I don't have a clinical education myself. Like it bothers me, right? And I know like if I show that to my clinical collaborators, they will just stop paying attention to what I'm saying because they're like they can't take that seriously, right? It's sort of like again like to go back to the example of like if you had a computer vision problem and like all of your street pictures are upside down with the sky in the bottom for no reason, right? It just makes it difficult. So I think like just having the interaction with the physicians is useful for that kind of thing, but it also like helps us not even just individual students, but I think like it helps my lab as a whole to have those conversations very regularly, because like sometimes what you think is the problem is not really what the problem is, and like just seeing the surgeon at work or the physician at work doing what they're doing and seeing like what the pain points are, so that you can develop a solution for that, as opposed to just saying, here's the method I have, here's like, let me apply the same method to every problem I see, right? Like that what's that saying with the hammer and the nail? If you have a hammer, everything looks like a nail or something. It starts feeling a little bit like that, right? Versus we find if we can customize solutions to the actual problems our collaborators are having, that's just a lot more impactful and a lot more fun for everybody involved, I think.
Yeah. Sheen, got something to add to that with the value of it in your experience?
Yeah, so I think students don't come with the idea of how crowded operating rooms are. They design like these things that they're going to put in there. I'm like, no, no, no. Let's go look. That won't fit. Or like, actually, just yesterday we are doing some kidney stone studies on phantoms, and we attached these AR tags on the OR monitor, and then it falls onto our phantom. I'm like, it won't happen. That would be a big problem. The patient would be sterile. Your tag is most certainly not. Anyway, let's fix that before. But also, I think the other part is our data is really messy, and that's something that surprises my students. So actually, I use some data not from OR, but from my own research robot that's generated with tissue and stuff, and like that's really messy. Nothing really works the way that you think it should work. So I think I used to running things on ImageNet, on MNIST, are these like clean public data sets that people have figured out how to load and process, and the data processing is a learning curve each time.
No, totally. I mean, the workflow is interesting. The messiness of the data, I totally get that. It's something where when you move something from bench to bedside, it's just a whole different environment. And if you don't have any exposure, or even just have taken data in those environments, have a surgeon kind of sit in there, get in the robot, and actually kind of do something. It's a whole different world when you're analyzing that data. So I totally get that. So another question for you, both actually, again, and this is dealing with just really short, one sentence kind of, or one couple areas, big horizon for AI and kind of your areas. You're in interventional image analysis, intelligent robotics. What are kind of what's one of the big problems out there that everybody's going to go after, or what's on the horizon in terms of that kind of a short, pithy thing? What do you think?
I would say it has to be trustworthy AI, because there is like just like there is, if you're on a plane and it's an autopilot, you want to know that it's functioning exactly as it should. We want to have that, especially in these surgical applications where it is real time, just like the autopilot is, right? We want to have trustworthy, reliable, robust, and we want to know what kind of exactly guarantees we can put on the performance. So I think there's a lot of reliable, explainable, trustworthy AI is a lot of the challenges there for clinical take-up of these tools we're developing.
Yeah, how do you trust it, right? That's what it comes down to. I get that totally. Jiying, what do you think?
You kind of took my first thought, so I'll go with my second.
Sorry.
Which is also a little
Always
bit,
the order you ask, right? Who is first in first?
right? But it's also opportunity. So I think a challenge is how do we deal with all the multimodal data that comes through a robot system, that not only do we get an endoscope image, now we also get how the surgeon actually moved their tools. We could bring in pre-op images to add to this multimodal setting, but we have really good neural networks to process images. We don't have good neural networks to solve multimodal challenges. So I think there's a both challenge and opportunity in how we process the full collection of data we could get.
Oh, that's fantastic. My last question was parting advice. If you have 10 seconds apiece, parting advice for students thinking about this domain, or any kind of thing you want to kind of put out there for them. What do you think? I'll go with you first, Jiying.
Go talk to your surgeon, figure out what their real problem is, and develop domain expertise.
That's fantastic. Ipek?
Don't be discouraged by not knowing about the medicine. You'll figure out what you need to. Just work on what you do now, and you have something to contribute.
That's fantastic. Well, excellent. Thank you very much. I really appreciate you all kind of coming and take some time out to kind of chat with us. It's pretty much all we have for today. So thank you. I know you're busy, so I really appreciate it.
Thanks for having us. This was fun.
That's right. For all the folks that are out there, thank you for listening as well. I really appreciate you kind of coming in and listening to our 30 minutes, all the things that we're working on here. Last note, we have another panel next spring, so be on the lookout for that. If you enjoyed this, please take a look. We have a YouTube channel out there with 6 other videos on it, so you can learn about other areas that we've covered in the past. I always give my disclaimer at the very end, which is I'm no expert webcaster. I'm just an engineering researcher trying to learn. So if I fumbled and I bumbled, as I always tell my kids, I'll do better next time. So take care, folks, and thanks for watching. Take care.